For the sake of time, we'll go ahead and get started. We have a pretty full agenda, so we want to take as much time as we can to address any questions and give the panelists a chance to also discuss their research. So again, good afternoon or good morning, depending on your time zone. My name is Jacquelyn and I'm a program officer in the Research Evaluation Learning Unit at the Robert Wood Johnson Foundation. I want to welcome you to our first ever RWJF for Action panel conversation, COVID's impact on health equity and access to health and social services, a conversation across RWJF for Action programs. Today, we have the opportunity to hear from 3 investigators funded through the RWJF signature research programs who will share new research that examines the kind of infrastructure and cross-sector collaboration that improve pandemic response, the factors associated with the disparate impact COVID-19 had on communities of color, and state-level public health, housing, and education, and other policies initiated in the midst of the pandemic. We felt that it was really important to have this type of discussion since over the last 21 months, the impacts of COVID have disrupted our nation's health and social services system, in ways that many thought were unimaginable. All three of these projects that we will discuss today will touch on different parts of these systems, which is really necessary to address access. So our goal for this time together is to better understand what COVID has taught us about addressing health disparities, what's needed for cross-sector collaboration, and how we can better protect the most impacted communities in the next large-scale emergency. Before I introduce our esteemed panelists, I wanted to take a few minutes just to introduce to some and review for others what we consider to be the RWJF for Action programs. These are our signature research programs or pillars, and they're our research interests in how policymakers actually are using research to inform our decisions. So the RWJF Research Evaluation and Learning Unit now supports 5 signature research programs. And these programs are designed to fund multidisciplinary, multi-sector research teams that identify the root causes of and potential solutions for inequitable health outcomes in America. 3 of the 5 programs will be represented here today. And those are Systems for Action, which funds rigorously designed scientific cross-sector research projects that investigate how to better align and coordinate the delivery and finance systems needed to build a culture of health. Policies for Action, which funds research that identifies policies, laws, and other systems and community levers in public health and private sectors that can build a culture of health. Evidence for Action, which funds investigator-initiated, rigorously designed scientific research to address gaps and the knowledge needed to inform, develop, and redefine strategies to build a culture of health. The final 2 that aren't represented here today, but I did want to mention those. Health Data for Action, it actually links research to health data sets and funds research using this data to answer important policy relevant questions. And our newest program that started December 1st, 2021 is Health Equity Scholars for Action. And that's designed to enhance the supports, resources, and community necessary for participants to thrive professionally and personally, and in turn be better able to contribute to and expand health equity related research and evidence that can build a culture of health. So in understanding the 4 action programs, part of our ongoing vision is to ensure that the signature programs successfully live up to the 4 action part of their names. I wanted to share a few examples where policymakers and legislators have actually utilized the evidence that was produced by these signature programs, which in turn has actually catalyzed action. One example is the Delaware Department of Health, which now conducts HIV and hepatitis C screening for probationary individuals on probation who were at high risk for the diseases HIV and hepatitis C, after the University of Delaware's Systems for Action study that examined a multi-sectoral approach to criminal justice probation services. Another example is the New England Journal of Medicine publication of the findings from the Harvard T.H. Chan School of Public Health about early changes in beneficiaries' coverage and employment under Arkansas's Medicaid work requirements. That was cited in a Supreme Court amicus brief, as well as covered by major media outlets, cited on social media, and it was also the topic of a podcast. Finally, the findings from the University of Tennessee Knoxville's Evidence for Action grant evaluated the Stockton Economic Empowerment Demonstration, which informed congressional legislation for a federal guaranteed income pilot in several large US cities, which are scaling up the structure that was used in the experiment to implement similar pilots. So RWJF established these signature programs to not only generate the evidence about what works to improve population health, well-being, and equity, but also to translate and disseminate it to audiences who can act on these findings. And while we have faced challenges in this space, we will continue to embrace efforts that continue to support a broader culture of health. And I now want to turn to our research focus. RWJF in the past couple years has shifted a bit in their research focus. And so this is all rooted in the belief that everyone should have a fair opportunity to lead a healthy life. Philanthropy and research have often teamed up to address health inequities within the United States. And these inequities actually became glaringly clear during the pandemic. And while I provided previous examples that support our strengths, we know that there are still challenges and opportunities that come with this work, and we continue to take steps to improve these areas within our research portfolio. As we continue to grapple with COVID-19, RWJF is looking to move beyond research that shines a light on health disparities and provide evidence of what works to address the multiple domains of racism, structural, interpersonal, and cultural, and also remove barriers to health. And while we are focused on racism and health, we know that in order to reach a culture of health, we must be honest about the fact that too many people in the United States start behind and stay behind because they don't have the same opportunities as others. In recent months, we have amplified our voices through publications, calls for proposals, as well as resources that speak to these areas. One example is a editorial that was published in the American Journal of Public Health, where we called for a number of opportunities to address how we can support community healing and dismantling structural racism. Those include revamping data, especially through data disaggregation and improved data systems. And I want to also mention the National Commission to Transform Public Health Data Systems, which was developed by RWJF, and there's a lot of information that is out there that we can get to you all regarding that, as well as amplifying the message that institutionalized racism is a fundamental cause of health inequities. Tapping community power by centering people who bear the greatest disparities in research design, implementation, as well as policy advocacy. And just to wrap up, I also wanted to cite part of a perspective that was shared in the New England Journal of Medicine by our former president, Dr. Risa Lavazzo-Moray, and our current president, Dr. Richard Besser, and a board member, Dr. David Williams. Researchers and policymakers increasingly understand that health solutions must target manifestations of structural racism, such as barriers to economic mobility, access to high quality education and healthcare, and access to high paying jobs, and the policies that allow racial inequities to persist. Health system researchers should continue moving away from focusing on health disparities and toward looking at root causes, systems of structural racism. Only by addressing underlying structures will we get close to a day when a person's health prospects are no longer predicted by the social construct of race. And with that, Carrington, can you go to the next slide? This is our agenda for the day. I've already done the welcome. Again, my name is Jackie Orr. I'm an RWJF program officer. We'll then have, next we're gonna have presenter discussions. I'm gonna provide some introductions for all of our panelists. And then we'll have presenters discussions, and then I'll moderate some questions and answers for everybody. Next slide. And we also want to ask everybody, if you want to join our discussion on Twitter, please use the hashtag COVID Research Webinar. Next slide. So I'll get started with our introduction. So Julia Raifman is an assistant professor at BU School of Public Health, and she leads the COVID-19 US State Policy Database. Julia's larger bio is included on the slides, but for the sake of time, we'll move forward to the next slide. Aditi. Aditi Bhanja worked as a research project and data assistant at the Harvard T.H. Chan School of Public Health. Her work spanned both health policy and healthcare management and included research on the Affordable Care Act and related policies, as well as the dynamics and optimization of healthcare teaming. Her prior research work consists of understanding the impacts of migration, disasters, and crises on population health. Overall, Aditi is passionate about turning research into action. Next slide. Nadereh Pourat is Associate Center Director at the UCLA Health Policy Research, Professor of Health Policy and Management at the UCLA Fielding School of Public Health, and Professor at the UCLA School of Dentistry. Dr. Pourat's research focuses on assessing disparities in access to care of underserved populations, including the role of the healthcare delivery system in disparities in healthcare outcomes. She has extensive experience in evaluations of national, statewide, and local programs using mixed method evaluation design. I want to welcome all three of our panelists. So the remainder of the time, this is what we're going to do. We're going to have each of our panelists take about 3 minutes to introduce their project, and then we'll cover 3 questions about each of those projects. From there, we want to have at least 10 minutes for question and answer from the audience. So again, please put your questions in the Q&A section so we can keep track of those. We hope to get to as many questions as we can today. If not, we will try to follow up via email with those. So next slide, Carrington. So again, these are our RWJF funded research projects. We'll start with evidence for action, the COVID-19 US state policy database, and then go to our policies for action program that talks about COVID-19 related insurance coverage changes and disparities in access to care among low income US adults in 4 southern states. And then our Systems for Action project, which talks about using whole person care to coordinate health and social services for Medicaid populations during the COVID-19 pandemic. And all 3 of these 4 action programs have websites, and their information is available online. So you can also find that information there as well. With that, I'll pass it over to you, Julia. Thanks.
Hi, thank you so much everyone for being here. It's a pleasure to have the opportunity to connect with you all. I'm Julia Raifman. I lead the COVID-19 US State Policy Database. We started the State Policy Database in March 2020 because we knew that it would be important for researchers to be able to conduct research on how state policies shaped the spread of COVID-19 and economic precarity in the wake of the pandemic. So we tracked the date that states changed more than 200 policies to prevent COVID and address economic precarity. And we are just so impressed by all of the research that several people, likely some of you on this call, conducted using the data. We still keep the data updated. It's at statepolicies.com, and I'll share that in the chat. And we've learned a lot about the pandemic through the research based on the policies data that we compiled and more widespread research. So some of the things that we've learned about the virus are that it spreads through the air, not on our mail. It spreads in crowded indoor settings, whether that's a grocery store or a workplace or a school. We've learned that masks and ventilation are key to reducing spread through the air. And we're so fortunate to have the development of vaccines that are very effective for reducing severe disease, hospitalizations, and deaths. We've also learned that rapid tests are an important tool for addressing the pandemic. And we've seen that eviction freezes were an important tool for reducing spread, and that policies like unemployment insurance and stimulus checks were important for reducing economic precarity during the pandemic. In the second year of the pandemic, we've really turned a lot of our focus to emphasizing how policies can help support the way ahead, and a focus on equity. And so I think there's actually a lot of room for improvement. We all hoped that the pandemic was ending, and that we would reach 100% vaccination coverage at this point, but that's not how we've seen things play out. The virus has given us some surprises, and I think now we should learn the virus is characterized by repeated surges, whether that's due to seasonality or new variants. And the good news is that policies can really help us manage the virus, so it does not manage us. And we see the destruction that the virus can cause when we're not using all of our policy tools to really scale up and make equitable our pandemic response. So some of the policies that we see are most important really scale up and make widespread our most effective tools. So those are vaccine mandates, mask policies that help everyone mask together most effectively to clear the air of COVID, rapid testing strategies, and ventilation standards and workplace safety standards. So we're glad to see some recognition of the role of these tools and making them more available can have in the future of pandemic response. And I think this is a really important moment to reset our policy response a bit, to recognize that we've seen surges now in July, in November, and in December. And it's quite possible we'll see surges again, but our policies can help us control it. And so a lot of what we're doing is trying to communicate about policies, trying to communicate the facts, because in the pandemic discourse, sometimes we can lose track of the facts. It's very important to put those out. And we really try to exercise the principles of disaster response put out by the CDC, which are to be first and be right, to keep putting out the facts, to have the facts outweigh misinformation and disinformation, and to let people know about actions and the importance of coming together to take collective action to support the whole of our society. What we're seeing is that if we leave anybody behind, we ultimately leave everybody behind. And we hope that the policy database can facilitate more and more research on this, as well as communication about policies. One other tenet of what we saw in the state policy database is that the most important influence on state policies throughout the pandemic has been federal guidance. And so the federal government plays a key role in helping respond to any disaster, and that's especially true in an unprecedented disaster like this pandemic that affects everyone in our society and affects our essential workers who continue to have the most exposure the most. So thank you. I'm looking forward to further discussion in the question and answer session.
Julia, thanks for that. Next, we'll have COVID-19 related insurance coverage changes, disparities in access to care.
Hi, everyone. So my name is Aditi, as Jacquelyn mentioned before, and I'll be discussing my team's research on COVID-19 related insurance coverage changes and disparities in access to care among low-income U.S. adults in 4 southern states. So part of this research, the objective was to determine changes in insurance coverage and disparities in access to healthcare. And so we asked ourselves 3 big questions. How is the COVID-19 pandemic associated with insurance coverage, access to care, and affordability of care among low-income adults? And how did this pattern vary by Medicaid expansion status? Our second question was, how do these patterns differ in analysis stratified by race and ethnicity? And then our last question was, did self-reported barriers to healthcare use, including access to telehealth, differ significantly by race and ethnicity during the pandemic? So using a nonpartisan survey vendor, we conducted a random digit dialing telephone survey of US citizens ages 19 to 64 with family incomes less than 138% of the federal poverty line in 4 states, Arkansas, Kentucky, Louisiana, and Texas. And that survey was conducted from October to December of 2020. And so using a difference in differences design, we estimated the changes in our outcomes by Medicaid expansion status and overall, and by race and ethnicity in 2020 compared with data that we had previously conducted in 2018 and 2019. And so the first 3 states that I mentioned, Kentucky, Arkansas, and Louisiana, had expanded Medicaid, whereas Texas was our only state that had not. And because prior work suggested that the ACA coverage gains had largely plateaued by 2018, we used the baseline data from those prior waves specifically to compare with our 2020 outcomes. And the potential, and therefore the potential differences in changes in states with prior Medicaid expansion. And then we also explored barriers to healthcare and use of telehealth by race and ethnicity. And so without getting into so much of the details of the point estimates of the differences in differences, what we found was that there was worsening access to care in 2020 in all 4 states compared with the 2 years before the COVID-19 pandemic and recession. In particular, coverage rates dropped in Texas, which had not expanded Medicaid. And we also found that Black and Latinx individuals living in Medicaid expanded states were largely insulated from the rise in uninsured rate compared with those in Texas. However, we did not find this result among white individuals. We also found that Medicaid expansion was associated with these large protective effects on coverage, though it was not associated with any differential change in access to care in either the full sample or the racial and ethnic subgroup analyses. And overall, in terms of having a personal physician and regular care for chronic conditions, low-income adults in 2020 experienced significantly worse access to care than the pre-pandemic years, regardless of state expansion status. We also found in our secondary analyses of more descriptive data on barriers to care and support, care support, 1 in 6 adults. So 15% had reported delaying medical care in the past year for non-financial reasons. And overall, while telehealth was rapidly used in the pandemic, we found that relatively low rates overall in the, we found relatively low rates overall in the low income sample, with a trend that suggests that rates may be lower in Black and Latinx communities, although that did not reach statistical significance in our study. And so overall, what we find is that, sorry, one second. Lost my note here. So overall, what we find is that during the COVID-19 pandemic and the 2020 recession, uninsurance rates rose among low-income adults, but in states with Medicaid expansion, that association was diminished among Black and Latinx individuals. And nonetheless, access to care across multiple measures worsened across all groups in 2020, regardless of Medicaid expansion status, which appears to reflect the new non-financial barriers to care that were created by the pandemic.
Thank you so much, Aditi. Next, we'll have Nadereh, who will be covering the Systems for Action project.
Good morning, good afternoon. I would start with talking about the project by saying that we are actually still in the process of conducting the analysis. Therefore, I'm not going to be talking as much about the findings of the project, but I would like to spend a little bit of time putting the project that we're conducting in the context of a much bigger activity that we are in the process of, and that is evaluating the whole person care program in California. It's now a 6-year Medicaid 1115 waiver program that the state of California has conducted to coordinate health and social services for high utilizing Medicaid beneficiaries. So the program that we're building on for the S4A proposal and grant was already in process, and it has it's a mixed method evaluation, and it has extensive information. I'll spend a minute talking about what this program is about. It's essentially identifying, sort of coordinating care across medical, behavioral health, and social services for the populations that are at the highest risk in the state. And it's acknowledging the fact that a lot of these individuals have multiple disadvantages and are that's perhaps the main reason why they're overusing acute services. So by nature of the program, it is identifying a much higher proportion of individuals that are from communities of color, and therefore our program is the whole person care program essentially is targeting those specific populations. So we built on that by trying to assess the impact of this whole person care program during the COVID time period. And the main goals of the S4A grant are assessing changes to whole person care pilot collaborative networks in response to COVID-19. A little bit more about the whole person care program is that it was implemented by 26 of the 58 counties in California. These are the most populated counties in the state, so they're the largest. And the program was to get the county, a county lead organization to build a collaborative network of providers, mostly social service entities, but also other behavioral health care providers, et cetera, in order to develop the program. It targeted specific populations, including those that are experiencing homelessness, individuals with mental health, severe mental health, and or substance use disorders, individuals that had multiple chronic conditions. And so it's really targeting the most disadvantaged populations. And the needs of these individuals included, housing and access to specialized services. So these collaborative networks were quite important in the actual implementation of the program. And then the second aim of our S4A project is to look at the impact of COVID-19 on enrollment, on service utilization outcomes by race and ethnicity. And then the third aim of the program is looking at what aspects of these specific pilots were associated with improved outcomes by race ethnicity. So let's see. So I think that is probably as far as we go. I can get into the details of the program further during our question and answer.
Nadereh, thank you so much for that. So Carrington, can you move to the next slide, please? What we're going to do is we'll address 3 questions. Each panelist will have an opportunity to answer each question, and then we'll have time for the larger groups questions that we have been receiving. Again, if you have questions, please put them in the Q&A section of the chat. Also, we will be sharing links to the editorials that we mentioned initially, as well as all of the research in a follow-up email. So first question, Nadereh, and I can ask you to answer this first. Are there promising innovations to address inequities that have been unveiled during the pandemic? And what learnings can we take away from how federal, state, and other stakeholders responded during the pandemic?
Thank you. So Well, so as I mentioned, I think the whole person care program that we are basing this project on is in fact really innovative, and following what California did, there's a national focus on doing similar things elsewhere. So I think this was a groundbreaking program, acknowledging the fact that, if you don't integrate care for individuals, you can provide all of the coverage that is needed, but people need more than just coverage to get to the services that are important in improving their health outcomes. So that is, I think that program by itself is quite innovative. But what the other aspects of this program that were really innovative is development of the infrastructure that's needed to integrate care, as well as the developing these public-private partnerships that are often really important to get the work of the public health systems expanded and more effective. So the things that we have learned from the evaluation, as well as the work that we were doing for this project, is that during the pandemic, there were two things that California did. One was pausing the process of requiring people to renew their Medicaid eligibility, and also streamlining the process for accessing other benefits like food stamps, the SNAP program. And we have heard from a lot of the stakeholders in our interviews that reducing the churn in Medicaid was really important during the pandemic. And also, so that kind of highlights how important it is to continue streamlining benefits, eligibility, and renewal processes after the pandemic. So that whole process of on and off, because and the difficulties of getting reinstated into Medicaid. So the second thing that we have relevant lesson that we have learned has to do with how this program was crucial in the county's efforts to deal with the pandemic. So what the counties were able to do was to use the whole person care resources to respond to the pandemic. They used the partnership networks, and they also used the data sharing infrastructure that they had to respond to the network. So for example, a lot of the staff that were in these programs were reassigned to deal with other urgent COVID response activities, but they were also able to use their experience and their connections with the enrollees in the pilot to quickly include them in or provide the important benefits to them. For example, they were able to get some of the unhoused individuals housed quickly because they were already enrolled in the program, or they had mechanisms to find them and bring them in, and also to deliver the kind of services that they needed. The data sharing infrastructures was also crucial because they could find people and outreach to them and enroll them or deliver the COVID related services as needed. So that also was the second important lesson that we learned.
Thank you for that. Aditi or Julia, do you guys want to add anything to this first question?
Yeah, I'm happy to speak to the role of policies in reducing inequities. What we see is that COVID since the beginning has been characterized by enormous inequities. So since the start of the pandemic, essential workers have had the most exposure to COVID. Now children have high exposure to COVID because they are in schools, which are crowded indoor settings. And we do see that the most COVID spread this fall was in children who are school age. So there is a lot of COVID spread happening in schools. And policies to reduce that spread really benefit the whole population, but they most benefit equity and they reduce inequities. So The most effective policies we have for doing that are vaccine mandates, mask policies, and ventilation standards. I think a lot of ventilation improvements have been made in higher income schools, but the lower income schools have been left behind. We also see that implementation is really important, and that vaccine mandates will help make vaccine coverage more equitable. Since this summer, we've been documenting that there's an enormous income gradient in vaccination coverage that persists today. And it's not just people who don't want to get vaccinated. There are a very small percentage of people who insist they will not get vaccinated across income groups. But what we see is that there are more low-income people who report wanting to get vaccinated but not yet being vaccinated than there are people who say they will definitely not get vaccinated. And that's still true today. We still have a lot of work to do to improve vaccine delivery. And we see similar patterns developing with boosters, where highest income people are 3 times more likely to have been boosted than the lowest income people. And so I think we need to recognize that routine vaccine delivery may become one of our most important strategies for combating the ongoing pandemic, and develop systems to make vaccine delivery equitable, delivering it through workplaces, really focusing on delivering it in low-income communities. And we see that this is possible because there are really positive outliers. La Collaborativa here in Massachusetts is an organization that works in Chelsea, one of our low-income communities, and they've achieved more than 90% vaccination coverage in their communities, whereas our other equity communities, 11 of them had vaccination rates of 60% or less in November of 2021. So I think we really see there's a lot of need to improve that now and going forward. And it's important for policymakers to recognize this, that when we use language like pandemic of the unvaccinated that can vilify the people who are unvaccinated, it may just be that they're underserved. It's a pandemic of the underserved. It's a pandemic of the low income. And we see that unvaccinated people are most likely to report getting COVID, but we also see that low-income workers, even those who are vaccinated, are far more likely to get COVID than vaccinated people who are higher income. So I think we need to begin documenting breakthrough data by income, by race and ethnicity, and by occupation. We need to better understand the severity of breakthrough infections, and we really need to make sure that we reach more, especially low-income people, with their first vaccines. We also need to make sure that there's not an administrative burden for vaccines, for rapid tests, or for masks, and that masks and tests are made affordable and available to low-income populations who continue to be most affected. So that means not requiring online appointments and several pages of online forms to sign up for vaccine appointments. Here in Massachusetts, you have to upload a picture of your insurance card. These are difficult things to do, even for me. I had to reschedule my appointment because I needed to make sure I had childcare for vaccine recovery, and I had to fill out the several pages of forms a couple of times. And I'm very motivated to go get my booster. And if it was hard for me, it's absolutely hard for someone who has less privilege than I do, who has less time than I do, less internet access than I do, less literacy than I do. And so I think we need to make vaccines delivered predominantly through walk-in clinics. We need to get people rapid tests and high quality N95 masks without requiring online forms and the education and internet to access them. So these are some of the things I think will be most important in having a really good pandemic response going forward. Obviously, we also need enough of we need to prepare for future surges. We know that surges characterize this virus, and we can prepare to have enough tests and masks for the next surge, but only if we begin doing that as soon as possible.
Thank you for that. So just for the sake of time, we've got about 19 minutes left, and we've got 2 more questions and a number of questions in the Q&A. So let's move to question 2, spend about 90 minutes apiece if we can on this question. What is the role of researchers in translating evidence for the public and decision makers in a quickly changing pandemic and political context? Aditi, we can start with you.
Sure, thank you. I think related to our previous point, but also this point, our study showed the power of surveying patients and getting timely data and how critical that is to the pandemic. Oftentimes, a lot of researchers will wait on administrative data for enrollment or insurance, and with surveys, you can get information fairly quickly. And there are, of course, hiccups with that, small sample sizes, the potential margin for errors and limited power and cost. But I think it allows us to contribute to the policies and decisions that are being made fairly quickly, and to do so as soon as we have some confidence of our findings. And having that ability to be nimble and to shift resources in public health emergencies is important. Also, having interdisciplinary teams that can work together to adapt data collection efforts is really key. And having access to multiple dissemination pathways and clear messaging is also incredibly important. And those, I think, are the main strongholds of researchers for translating evidence.
Thank you. Nadereh?
Sorry, I was unmuting. From our vantage point and our collaboration, frequent collaboration with state and other partners, I would highlight 4 different important things. And I would argue that you really need to start, if you want to translate information into action, you also need to start much earlier, working with your partners, trying to understand trying to translate the goals of the programs and policies into questions that actually can be evaluated and answered. So, a lot of times people come to you with goals that are broader, they're not measurable or not exactly clear. And so the first task is to ask the right questions. Then the other second thing is to identify questions that programs and policymakers are not asking, but are timely and actionable. So working with our partners, they're not necessarily thinking or don't have the same perspective as we do when we are doing these evaluations of what's happening. And we can point out what's important and could be really useful. So we've done that in more than once. Just because we also know what is, for example, in this case, where the state's going with the whole person care intervention, so we can offer suggestions. Testing the utility and the meaningfulness of the questions and data with program participants and stakeholders. You want to know that what you're going to offer as suggestions actually are implementable and make sense to people who are supposed to be doing those doing them in the future. And then lastly, disseminating data in accessible formats to informed lay audiences. So a lot of times when, journal articles are really not the right venue for transmitting information to broad audiences. So what we do a lot of times is provide these alternative forms such as policy briefs, where you do provide simple and uncluttered analysis that is easy to understand and is actionable for the audience. And I could provide examples of that.
Thank you. For the sake of time, Julia, I'm going to move to question 3. Can you answer question 3 for us? And then I'm going to move to the participants' questions after that. So what are the remaining unanswered questions around how we can help sectors or stakeholders work together in future large-scale national emergencies?
Yes, thank you for this question. I think one of the most important things going forward is for public health and economics and all sectors to work together, and also to center the people who are most affected by the joint disaster that is continuing to affect us, right? Like we still see huge surges of COVID disproportionately affecting our essential workers and low-income populations, as well as Black, Native American, and Hispanic people. And we see that food insufficiency continues, and that when people are missing work because of COVID, many of them do not have enough food to eat at a time when they're very sick. And so I think it's very important for economics and public health and people who are essential workers, people who are Native American, who are Black, who are Hispanic, and people who are from low-income communities to really lead us in figuring out how to best respond, how to design our policies equitably to protect those who are most vulnerable, and ultimately to protect the whole of our society. We see that when we don't succeed in protecting our essential workers, as has just happened with the Omicron wave, that then affects their businesses because there are not enough workers to stay healthy and at work. It affects their customers, who may also get infected and who may find businesses closed or services closed. It affects our healthcare workers, who must bear witness to the worst of it. And the thing is that we see every other G7 country except the United States and Japan have mask mandates, and Japan has a high level of voluntary mask wearing. And we see that policies like mask mandates can make a very big difference for reducing the harms of surges, protecting everyone, and especially protecting those most vulnerable. Similarly, like vaccine equity is important for protecting the whole of our society from all of these many harms. School closures, what we need to do is keep our teachers healthy and at work, and our students healthy and at school. And to do that, we can implement good policies that reduce the burden by quite a lot. The United States had 8 times more excess deaths during the Delta wave than other high-income countries. So that just gives you some sense of how much better things might be if we implemented better policies. Thank you.
Thank you for that, Julia. So we'll move into our question and answer session. Again, if you have any questions, please put them in the question and answer box, which is included in the Zoom, and we'll get started. So Alyssa asked, Julia, she wanted to talk about your points of communication, but we'll include that in the email that we'll follow up. So she just wanted to get your points on communication. So Alyssa, we'll make sure to include that in our follow-up email. There was a question from David who asked, we've seen a lot of huge natural experiments with states picking radically different policies. Are there studies of consequences of those different choices, like the number of infections, hospitalizations, and its length or mortality?
Yes, we've seen really fantastic studies. So the reason that we know mask policies are so effective are that there are lab studies really looking at individual mask wearing and finding that 2 people wearing masks is far more effective than just 1 person wearing masks. But also these policy studies where researchers in health affairs and in the CDC's morbidity and mortality weekly report, over different time periods, they took the same approach where they compared changes in cases before and after states implemented mask policies relative to over time in states that did not implement mask policies. And they found that there were immediate reductions in case growth that then increased over time because each infection averted reduced more and more onward spread. So these are very powerful, well-done studies. No study is perfect, right? We don't have many randomized trials. We have the Bangladesh randomized trial that doesn't really reflect what it's like when 100% of people wear masks indoors, but that does speak to more masking, reducing cases. And so I think, and then there was a question about mask quality. Absolutely, better masks reduce spread better. And we see that Germany last January distributed N95 equivalent masks to vulnerable people in the population there. Germany, Austria, I believe Greece are a few countries that require people to wear high quality masks, not just any masks, in their mask mandates. So certainly that would be a really smart strategy for us going forward. You know, we also recognize that people might not want to wear masks all the time. And so in that context, then we suggest data-driven mask policies as a really smart way to manage mask wearing and to wear them together most effectively when and where it's most important. So in any county that starts to have a surge, the mask policy would turn on, higher quality masks would be better. And really, masks N95 masks are expensive for low-income workers. And so we really need the federal government to provide them. I'm really glad to hear the federal government is considering sending everyone N95 masks. And I hope that's a strategy we'll use going forward for every surge, not just now, similarly with testing. Thank you for the question.
Thank you. So this question comes from an anonymous attendee. The question is, do you think that this push will push selected states towards Medicaid expansion?
I'm not sure who is directed at, but
well, I think Aditi or Nadereh, either one of you could probably answer that one.
Nadereh, why don't you go ahead?
Yeah.
Oh, Nadereh, please.
Yeah. So, well, I mean, I'm not sure, whether the so the pandemic probably had a relationship to increase in Medicaid enrollment. In California, we have been observing that there was not as much job loss as expected. That might have led to the increased Medicaid enrollment, but it did increase the decision to expand Medicaid. If you're thinking about the ACA expansion, seems to be a different type of decision than whether or not more people need Medicaid. I think that tends to be more of a political decision at this point because most of the states have already expanded.
Thank you for that. Aditi, did you want to add to that?
Yeah, I think, I mean, we saw in this pandemic, a real test of our U.S. health insurance system, right? And maybe one of the first major challenges since the implementation of the ACA. And so I think, yeah, the safety net of the Medicaid program really protects people, especially vulnerable communities like Black and Latinx populations from large economic shocks to the system. But there were also a few other, things that happened in response to the COVID-19 pandemic that were policies taken on by states that didn't expand Medicaid at the federal level. So like the Medicaid maintenance of eligibility for non-expanded states, which may have protected many folks who were experiencing job loss and uninsurance from loss of insurance at the time of this pandemic. But of course, there are limiting factors to that, periods of public health emergencies and extending those that coverage and those benefits through those times. And so that changes a bit, and that has changed a bit in the last 2 years. But I think we do see this trend that extending these benefits is beneficial. And so I do hope that more states, especially non-expanded states, do adopt.
Aditi, since I still have you, there was one question from Perry Goldberg. How much did avoidance of being exposed to the virus at health facilities play a role in utilization of care? And did this explain some of the decrease in access to care in low-income samples?
Yeah, it did. Thank you so much for your question. So in our sub-analysis that we conducted on some barriers to care, for fear of contracting COVID-19, it was about 8.1% of our sample in 2020 that reported that that was the reason for delaying care for non-financial reasons. And that was slightly higher in white populations, slightly lower in Black and Latinx populations. But we did, so yes, I think that was a big deterrent, as well as, being too busy with work and family and some of these other reasons. So yeah, I think that was one of our prominent findings from that analysis.
Thank you. And just to wrap up, this will be our last question. The other questions that are in the chat, we will attempt to address all of those as well. But this question comes from Jennifer Barr. What social determinants of health do you think should be addressed by healthcare actors versus social support systems? And what determinants or aspects of inequality are healthcare providers best equipped to address? I think that will really help us to wrap this up in a pretty well, hopefully for everybody. But I'll ask Julia, can you start? And then Nadereh, and then Aditi can wrap it up.
Yeah, thank you for that question. I think COVID is really illustrative of how important the social policies and the prevention policies are, because by the time someone reaches the hospital, it's often too late. That is the last part. It's the last chapter of the book in COVID. And there are so many policies that can shape whether they ever end up there, whether they're vaccinated once they are there, and what happens to them when they are in the hospital. And so I think what we can do is shape a more equitable society with policies. It's been really interesting to track policies on economic precarity, right? Because we actually see there are several policies that leave out the lowest income, informal sector workers again and again. Minimum wage policies, unemployment insurance policies, paid leave policies, health insurance. And what we need to do is make sure that when we do have social support policies, that they reach people who have part-time jobs. They reach people who are independent contractors. This includes policies like the vaccine mandate in OSHA right now, right, which exempts small businesses and would again leave behind the lowest income workers. Paid leave considerations should really make sure to reach that informal sector and part-time workers. This is how I think about social determinants. And just to speak quickly to the question on communications, I appreciated what Ed Young said, which is the evidence doesn't speak for itself, and we have to speak for the evidence. And I think that's especially true in a time when the media is playing a big role in the pandemic response. And if we don't speak for it, then others will speak. And some of them have pretty extreme views that have affected our pandemic response. So we always try to center on the evidence, bring it back to the big picture of what's important and on the enormous inequities that continue to characterize the pandemic. Thanks again for the opportunity.
Jackie, I know we have very little time left, but I think Julia did a great job of talking about the social determinants. The only thing that I would add very specifically is the importance of housing and the tremendous challenges that we're facing with the shortage of housing and ability of the individuals to maintain. And that is one of the factors, one of the social determinants that has a very direct impact on health. And big problem, we just need more innovative solutions to deal with that.
Aditi?
I think both Julia and Nadereh have I can only echo their sentiments. So I think that also brings us to time.
Great. Thank you all for your participation and willingness to share your amazing projects with our participants. I definitely wanted to acknowledge the national offices for each of these programs. So the University of California, San Francisco, Evidence for Action, Policies for Action, the Urban Institute, and Systems for Action, the Colorado School of Public Health at the University of Colorado. Thank you all for your willingness to help us move this research that's very important forward. And we look forward to meeting and talking about this in the future. Thank you.
Thank you.